Okay, good afternoon or good evening, dear ladies and gentlemen. Let me to introduce you our today's guest, Professor Dr. Maјkl Fицџeralд. Today is the 9th webinar, and it's a really pleasure for me to introduce you our guest who is coming from Dablin, Ireland. Professor Dr. Maјkl Ficџeralд was the first professor of child and adolescent psychiatry in Ireland, specializing in autism spectrum disorders. He has diagnosed over 5,000 persons with autism spectrum disorders. He has a large number of peer-reviewed publications and 36 books written, co-written and co-edited, including Japanese, Dutch, Polish translations. Professor Simon Baron Cohen of the University of Cambridge described one of his books on autism as the best book on autism and described him as an exceptional scholar. He has lectured extensively throughout the world, including the Royal Society, British Academy and the British Library in London. He is the overall winner of the Excellence in Psychiatry Award in Ireland 2017 and was nominated as one of the top 4 psychiatrists by Hospital Professional News Ireland, top 100 professionals in Ireland for 2017. You can see on the screen his website, and he has there 10 free books, free for download without charge of money. And also his impact on his Hirsch index on ResearchGate is 50, which is a really high impact score. Information on his papers are available on ResearchGate, Academia, and his website. Now, Professor Ficџeralд, let me a little bit to switch on Macedonian because most of the guests are from Macedonia. 1 or 2 minutes to translate some of these things and to give them some technical points, and then I will give you the floor. Почитувани дами и господа, добре дојдовте на деветтиот вебинар на МНЗА гостите од странство. Ви благодарам за вашето присуство. Исклучителна чест ми е да го најавам професорот Мајкл Фицџералд. Сосема накусо, предпоставам дека разбирате англиски, сосема накусо, значи да ви спомнам дека тој е добитник на наградата за 2017 за топ 100 професионалци во Ирска, прв психијатар со преку 5000 преведени, тоест преку 5000 прегледани деца и лица со аутистичен спектар на нарушување. Има 36 книги напишани, од кои што 10 можете слободно да ги симнете на англиски јазик на неговата веб страница. Ние продолжуваме со вебинарите и во март. Веќе ви беа најавени на социјалните мрежи 3 вебинари, но за тоа на крај. Почнавме со Microsoft Teams заради тоа што имаше навистина многу пријавено, иако во моментов не гледам многу, 216 пријавена, во моментот 40 сме присутни, така што можевме да одиме на Zoom, но за сега во четот ќе го следите на официјалниот YouTube канал. За тие што не разбираат, можат и таму да ги следат, значи како сижирани информациите од секој слайд што ги подготви техничкиот секретар на списанието ИРТД, Андреја Ивановска. Овде во четот нема технички можности, бидејќи од УКИМ и од факултетот е блокиран четот за надворешни гости, а преку 99% сте надворешни гости. И окей, сега веќе ќе му дадеме збор на него, да не должа многу. Сега ќе му дадам збор на професорот, а вие уживајте во неговото предавање, кое што носи наслов Контроверзии на аутизм, дијагнозис, третманот and creativity. Professor Ficџeralд, our secretary Vesna Filipovska already share your slides on the screen. Probably you can see them. And you can start with your presentation. I will go off during your presentation with my microphone and camera. And when you will end, then we will start with discussion. Every one of the guests can go with camera and audio and ask you a question, because there are some problems with the chat. So live with camera or only with audio, they should ask you after your presentation. Please, you can start.
Okay, thank you very much, Professor Trakowski. I'm very grateful for you for inviting me and for setting up this. Could I? Most of my material is available on ResearchGate in academia and on the website. So could I have the next slide, please? We're not sure about a lot of things in autism, and we have to be careful if we meet people who know everything. We do not know everything about autism, and we're far from it. Next slide, please. Even the issue of what is autism is a controversial issue. I have no doubt that if there's any parents looking in tonight, they will know what autism is from their child. And parents of children with autism are often the best experts on autism. But nevertheless, autism does remain a very controversial subject, and the diagnosis is controversial. There was an attempt to get pure autism. Now, the idea of pure autism is ridiculous. There is no pure autism. And the Autism Diagnostic Observation Scale was set out to diagnose pure autism, but it failed. So we have huge conflicts in the diagnosis of autism between narrow autism. This was developed by Professor Michael Rutter, who sadly died recently, and which is characterized by, I suppose, Kanner's autism and ADI, the Autism Diagnostic Interview and the Autism Diagnostic Observation Scale. And then true autism, as I see it, which is the broader autism phenotype, and that is what most of us believe autism is today. Nevertheless, we have huge validity problems, and as you can see, I'll just run through it quickly. The diagnosis of autism, according to DSM-5, that's the American Psychiatric Association classification, is persistent deficits in social emotional reciprocity, problems in nonverbal behavior, problems with social relationships, and two of the following items that are mentioned there. Your stereotypies, preservation of sameness, keeping things the same, narrow interests, and hypo and hyper sensitivity. Could I have the next slide, please? Just one word about ICD-11. That's the International Classification of Diseases 11. It's just coming out and is available online. This is produced by the World Health Organization. But both of these diagnostic algorithms, they should only be considered guiding principles which can help organize information. So when you're making the diagnosis, it's a clinical diagnosis, and there is no boundaries really between most diagnoses in psychiatry. What we have are dimensions, not categories. When Kreplin was around, we thought we could separate schizophrenia and bipolar disorder, but these now overlap, so that the old paradigm of narrow diagnosis and categories is gone, and diagnosing autism, according to the National Institute of Mental Health, INSEL, is like the quality of fever in patients. In the old days, a doctor would say what the level of fever was. So that's the kind of level that we're at with autism. And of course, the subthreshold autism, that's diagnosis below the cutoff point, is continuous with full autism. So really what subthreshold autism means is mild autism, and some patients with subthreshold autism or mild autism, they will also need help. And the normal variation and the extended end of the distribution of autism are continuous. And of course, one of the big problems with autism is the autistic traits are seen widely in the general population. So what we're left with then is the clinical gestalt. That's our gut level idea of what autism is. Now, Rutter, he set out to logically articulate the structure of justifiable beliefs about nature, and he thought he could do this for psychiatry. And of course, Peter Medawar, the Nobel Prize winner, he had set out that was the task of scientists, and Rutter tried to apply this to psychiatry. But the project was unsuccessful because psychiatry is a different kind of paradigm to other disciplines in medicine. And we have a lack of specificity in psychiatry. That's the big problem. And even in treatment, as well as in characterizing disorders, they're characterized by non-specificity. And this is something we have to face up to and develop a new paradigm. I mean, ADHD would be one of the most common comorbidities in autism. If somebody says they have a child with autism, the next question you should ask, what else have they? And a great majority will have 2 or 3 other diagnoses like oppositional defiant disorder, depression, anxiety, and so on. But comorbidity is greater than expected due to overlap and similar etiological factors. The autism, ADHD, and many of these other conditions, they have some overlapping genetics. So it's hardly surprising then that they're not separate. And we did a study on ADHD and autism, and ADHD on its own. And then we had a group which we called ADHD combined type, that's inattentive and hyperactive type. And these were the ones that had the most autistic symptoms. Next slide. Now, autism and schizophrenia, according to Kreplin, were separate conditions, and Rutter said that childhood schizophrenia has outlived its usefulness and should be confined to the history of psychiatry. He also said that autism and schizophrenia are different disorders. He said that autism has nothing to do with schizophrenia. Of course, this is absolutely incorrect because autism can overlap with schizophrenia. And if you take John Nash, the Nobel Prize winner, he had autism in his early life when he won the Nobel Prize, and then in his later life he developed schizophrenia. So he had both conditions. Many of you will be familiar with him from the film A Beautiful Mind. And many of us nowadays, we put schizophrenia and bipolar on the neurodevelopmental spectrum as well, with autism and ADHD. Early diagnosis is absolutely critical because the best outcome, everybody agrees, is when you have early diagnosis. And this gives you a reason. The possibility of ASD diagnosis is 0.79 at 14 months and 0.83 at 16 months. For many years, or not for, well, for the last 5 or 6 years, 7 years, when I was diagnosed, the children I was diagnosing were between 1 year and 1.5 years. And because there's such a sensitivity to autism now, parents are bringing their children for diagnosis between 1 and 1.5 years, while 15, 20 years ago, they didn't come till 3 years of age. And before that, they didn't come until age 5. Now, I made a provisional diagnosis of autism in the relevant children between 1 year and 1.5 years. And I've always asked the parents to ring me if that diagnosis was wrong. Nobody has ever rung me to say the diagnosis between 1 year and 1.5 years was wrong, even though I always describe it as provisional. So you have the best outcome when you make the diagnosis at that age, and the only way you can get skill of making the diagnosis at that stage is by seeing hundreds and hundreds of children with autism. That will give you the clinical gestalt, which will allow you to be pretty accurate, even between 1 and 1.5 years, that a child probably has autism. Next slide. In terms of screening, and we should have universal screening in every country. I believe every child between 18 months and 2.5 years should be screened for autism. In the old days, they were screened for infectious diseases, many of which we don't have much now. So we should switch to screening for autism. Certainly under 5, and as you can see, the UK National Screening Committee does not recommend this. They claim the tests aren't valid and that screening may delay correct diagnosis. I have never seen that. They also say that we don't know the benefits versus harm of screening. The only harm I've seen is people not being diagnosed and not being screened, but there are nevertheless the screening instruments they are problematic, and they're far from perfect. But if we use 2 screening instruments like eye tracking and one of the questionnaires, we may get better screening approaches. Next slide, please. This gives you the, 2 screening of the social responsiveness, social communication, where they only have mediocre specificity, but nevertheless, Guthrie in 2019, he found a prevalence of ASD obviously at a screening level of 2% with the modified checklist for autism in toddlers. And at follow-up, this instrument had a sensitivity of 38% and a positive predictive value of 14%. And of course, this screening should be, it's the general practitioners and pediatricians, they should be doing this. If we move on now to diagnosing autism, and this again is a controversial topic. Now, the National Institute for Health and Clinical Excellence, this was set up by the British government, and it gives guidance to professionals on how to diagnose autism. And it's an excellent book worth getting. But it points out very clearly there's no instrument for clinical diagnosis of autism, and they said that the instruments, indeed they have harmful effects in that they miss many cases of autism. But you can later on, you can use instruments for gathering information. You can use there's hundreds of screening questionnaires. You can use those for gathering information from schools and so on. That's excellent. But the diagnosis at the end of the day is a clinical diagnosis by an expert in autism who puts all that material together. And as von Baum says, validity of case status determination does not reside in any instrument or its scores. It requires a higher order interpretive process. And here he'd be referring to the ADI-ADOS, I've already mentioned it. That just the scores you get, they are not satisfactory certainly for making a clinical diagnosis. They can only be done by a clinician with experience in autism. And in terms of survey methodology, von Baum points out there's no standardization in autism survey methodology. So that's a severe criticism of epidemiology. I'll deal now with these instruments, the Autism Diagnostic Interview, which many of you will know, and the Autism Diagnostic Observation Scale. Both of these are semi-structured instruments and are used widely throughout the world. They're the most commonly used instruments. You still have to use them if you want to get a paper published in a peer-reviewed publication. You won't get it published if you're doing unless you say that your clients met the criteria for these instruments. But that's a political position, and this instrument has been heavily criticised because this instrument misses so many children with autism. I just go into the criticisms of it, and as you can see there, Professor Bishop from the University of Cambridge, the problems are not just financial cost, but it is hugely expensive, but the cost in time, scoring, etc. Next slide. Professor Bishop says if it could be shown to be a benefit to use this protracted, long drawn out, expensive procedure, she'd be happy to say okay, but this has never been demonstrated. And so there is huge faith in Britain in ADI-ADOS. You know, it's an article of faith that this is the way to diagnose autism, and it's incorrect, and it goes against the guidelines from the National Institute of Clinical Excellence. Next slide. Next slide. Yeah. And even scoring above or below the threshold for this is not sufficient for diagnosis. So, but this battle nevertheless goes on, this battle between narrow autism of Rutter and Canner and broad autism of Lorna Wing. And the gold standard, as I've said 4 or 5 times already, is a clinical diagnosis by an autism expert. Next slide, please. People come to me with a diagnosis. This is a non-diagnosis, but parents come to me in tears and they say their child is ADI negative. And then I look at the school reports, I assess the child myself, and autism is clearly present. And these children, the reason the parents are in tears is these children can get no intervention, they get no school supports, no treatment, no home tuition. So this is a disastrous diagnosis. I do divide autism into 3, I suppose, categories of severity: mild, broader autism phenotype, and then you have moderate autism, ADI-ADOS, and you have severe autistic criminality, psychopathy. This is a rare one, but if you have severe learning disability in autism, they would fit into this number 3 category. In my experience, 95% of parents who claim their child has autism are correct, but unfortunately in my country many people don't listen to parents. The prevalence of autism has varied widely. I started studying this about 1973, and that study wasn't published in 84. But at that time, 4 per 10,000 was regarded as the prevalence of autism. In 2006, Baird published a paper, an epidemiological study of autism, where she found 24.8 per 10,000 narrow autism and 116 per 10,000 broad autism. You can see there the huge problem using narrow autism, that you deprive so many people of a diagnosis of autism and treatment for autism. Now, there's no perfect prevalence of autism. There's no absolute prevalence of autism. But one paper that did get closest to it came in Korea, 2.6% per 100, and then the Center for Disease Control in America, the main center monitoring these things in America, put the rate as 1 in 44 in 2021. And I believe that those Kim and the center they're the best diagnosis, the best correct diagnosis we have. 2.5% of the population, I believe, have it. Next, and just the last thing to say is that the idea that autism is 1% of the population is completely wrong. So I looked at different. This is a doctoral thesis. I looked at different rates of autism in 309 persons. They were referred for assessment, and of those 309. 272 met the criteria for Lorla Wing's autism diagnostic checklist. It's now called the DISCO. 120 met the criteria for Kanner and Eisenberg's 2 criteria. 144 met the criteria, the WHO, ICD, and 24 met Kanner and Eisenberg's 5 criteria. But if I was to say which of those is correct, it would be the Lorna Wing's level. Now, diagnosis, obviously psychiatric diagnosis have huge problem. Stephen Heyman, he was the director of the National Institute of Mental Health in America, Washington, he said DSM is totally wrong. It's an absolute scientific nightmare. Thomas Insel said that our diagnoses have no reality. He was also director of the National Institute of Mental Health in Washington. He said our diagnoses have no reality, they're just constructs. And Waterhouse says our diagnosis lack biological and construct validity. And of course, the Kraepelinian or that categorical model is on the way out. I'll come back to some of this again. So we have 2 groups of researchers in autism. One are called the lumpers. They're the autism spectrum people. They're the broad autism, and the splitters. These are the supposed to be the super scientists that have this categorical autism, which I regard as absurd. So the lumpers have won, and so what we have now are really a total lump of disorders under neurodevelopment. Neurodevelopment just means that the disorders have an early development in childhood and that they affect personal and social relations and that. And so the DSM-5 has learning disability, ADHD and autism tics, but schizophrenia and bipolar are put in a separate category in DSM-5, but I believe they should be put under the neurodevelopmental category. Next slide. So the splitters, they go into fine detail about trying to produce categories which I believe are mythical. Now, as I said earlier, the DSM and the ICD-10, those are they give you an indication, a kind of prototype of what a diagnosis is. But I want to add features that I have discovered commonly in autism, and one should consider autism if you notice these features. When the child comes into your consulting room, generally they're very clingy to one parent, and when I would ask them a child a question, they'll run away and hide behind a parent. They will answer every question with "I don't know," or they'll give minimal information to questions. Next slide. They're super sensitive to criticism and bullying, and of course, I'll come to that as well. They ignore the unwritten rules of games. That's why they find it hard to play soccer or whatever, because soccer is played by unwritten rules. People break the rules all the time, and that's why you have referees. So they're really played by unwritten rules as far as the players are concerned. Only the referee plays by the written rules, and people with autism can't understand these 2 sets of rules. They have severe preschool aggression, biting and kicking. Here the issue is the severity of it. It's the extreme aggression, the extreme biting, extreme kicking. and they have severe, long-lasting meltdowns with an autistic cry. By that I mean it's the most horrendous kind of cry, very high-pitched and different from other meltdowns that behaviourally disordered children might have. They often show school non-attendance. Any child who's not attending school should be checked for autism. And I have dealt with adults as well. And with adults, I find quite a few of them, they stay at home housebound and can't go to work. The children with autism tend to shout out random thoughts in class. They'll disclose inappropriate family information. They behave as a class clown to get attention. They will say, "Have you friends?" And they tell me, "Everyone is my friend." And when they come into your office, they will tend to sit in the parental chair. When you sit in your office at your desk, the chair nearest to you is where the parent normally sits. But if the child has autism, they will tend to sit in that chair. Now, if it's an adult with autism, they will always sit in the chair farthest from the doctor. They have massive imagination. Lorna Wing said that they had no imagination. That was one of parts of her triad. That was the only thing she ever got wrong. And, you know, Jonathan Swift and Hans Christian Andersen, Melville, and many others had autism. Winnicott talked about comfort blankets as transitional objects. In actual fact, I see with children with autism, they have these objects, but they're autistic objects. These are often pieces of cloth or whatever. They have identity diffusion. It's very central to people with autism, and that can include gender identity diffusion. And you know, gender dysphoria is much more common to the person, and is caused by their autism psychopathology, and then there's probably a non-autistic gender dysphoria type as well. They often show an autistic narrative. If any of you, and I don't think there's many present, have ever tried to read James Joyce's Finnegan's Wake, this is extremely difficult to read, and it's what I call an autistic narrative. James Joyce had autism, but they gave no context to what they're saying, and they don't take the listener into account. If you move on now to the next category, autism and personality disorder, according to the obviously classifications, personality disorder is separate from autism. Well, that's not necessarily so. And actually, when you make a diagnosis of personality disorder, you should also check out to see, do these people have high functioning autism? And there's a major overlap between autism and personality disorder. You know, personality disorder is supposed to have emotional indifference, suspicion, fear of others, brief psychotic episodes. And of course, it's important to state that brief psychotic episodes can also occur in autism. Next slide, please. These are also features of a personality disorder that can occur in autism. That's odd beliefs, preoccupations, ruminations, failure to conform, and impulsivity and irrationality. Next slide. Next slide, please. So if you see children with deficits in neurocognition during childhood, it's been shown in the past that those children often showed to have personality disorders during adulthood. Well, I would say those same children often show autistic disorder in adulthood as well. Next slide, please. So the types of personality disorders are confused with autism. Well, the schizoid personality, many of those actually have legitimate autism, used to be called Asperger's syndrome. And that was shown by Sula Wolf and also by Christopher Gielberg. So those schizoid personality and autism are, you always have to check which are present and which would be the best for treatment. Schizotypal personality, which have odd language and so on, they often can be confused with autism. Narcissistic personality disorder, they often have a huge opinion of themselves and etc. And when you make a diagnosis of narcissistic personality, you should always check out for autism, as you should with avoidant personality disorder. Probably the most common misdiagnosis of all, is borderline personality disorder. And as you know, people use that phrase when they don't know what diagnosis to give to a patient. They tend to give them borderline personality disorder, which is a very unsatisfactory diagnosis. The borderline people have unstable relationships, like people with autism. They have fear of abandonment, they have impulse control, they have self-harm, they have explosive rage, and feelings of impetus. So you can get all those can occur in borderline personality. They can also occur in autism. So it's important to make it to do the differential diagnosis. And the other one that's very common in my country is that obsessive compulsive personality disorder is diagnosed when the patient have autism, because autism isn't well known in adult psychiatry, and when an adult psychiatrist meets an adult with perfectionism, a lot of control, rigidity, etc., they tend to diagnose them with obsessive compulsive personality disorder. The problem there with all of those is that if they're misdiagnosed as personality disorder, then they can't get the treatment they need, and that often leads to depression. In actual fact, in adult psychiatry, most patients with autism are diagnosed with depression, and the underlying autism is missed and never considered. Then they're treated for the depression. They don't get better, and it's no surprising they don't get better and have resistant depression, because the fundamental problem, the autism spectrum disorder or ADHD, which is missed equally, is not treated. Now, most patients with autism, they're very highly moral. They admit to everything. They're the opposite to what I'm describing here. But nevertheless, there is a very small group. Criminal autistic psychopathy is less than one. I don't know what it is, less than 1%. But I tend to use it when there's criminality and autism combined. And this has been recognized since 1944 and earlier. In actual fact, it was Asperger in 1939 who first described autism in modern times, and Kanner plagiarized it from him and never admitted to plagiarizing him. But that's another story. So even in 1944, we had children who were aggressive with autism, lashed out at other children, attacked other children with hammers, were inveterate liars, showed autistic acts of malice and sadistic traits. And so there's another myth that persons with autism can't lie. That's rubbish. Or that people with autism can show malice. Indeed, they can. All of these references here are all showing the same thing. They're really saying there's no link between autism and criminal offending. And in Mesibov said, autistic people never are never malicious or show unscrupulous motives. Obviously, that's not true, and I'm going to show that. Next slide. The prevalence of autism, aggression, now about 20%. I mean, when I was doing clinical practice, I would go out I often saw my patient in a car because they wouldn't leave the parents' car to come in to me. And I've seen parents, their faces mutilated, having been beaten up by their sons with autism. So there can be aggression in children with autism. Sapona, in a study of young offenders, found 30% of them had an autism diagnosis. Next slide. We don't need to deal with this, but these are extremely rare, and autistic serial killers are extremely rare, but they are in Eastern Europe and so on. Next slide, please. So the kinds of criminality that persons with autism, or even adolescents with autism, is arson. They're shooting in school, and Adam Lanza was diagnosed with autism in Yale University, and he engaged in that. Poisoning is another kind of form that they can go in for, and their killings are bizarre, they're random, they misinterpret other motives, but when they're caught, they often admit everything. And I've seen 2 or 3, and I'm more reading them in the newspapers than anything else, even in our country, where persons with autism have killed one of their parents. So if a child with autism make threats to their parents, or serious threats with guns or anything, you would want to take it very seriously, and they shouldn't be. They are fascinated by guns, but they should not be trained to use guns because of age. So that's the care model. Which now, if we go on to the miracle cure model, well, there is no miracle cure model, but in America they do seem to come up with some miracle cure every 6 months. They usually cost about $200,000 or $300,000, and sometimes they lead to death, but they certainly never cure. But applied behavioral analysis in its extreme form was supposed to give you extraordinary results and make people indistinguishable from normal. New paragraph. But this treatment has been very heavily criticised, because at follow-up, the children who had this so-called miracle treatment showed robotic behaviour, lack of emotions, their identity was suppressed. They had problems with generalising. Well, they had problems generalising their treatment to outside the treatment session, and they had problems with neurodiversity, and they were heavily criticised by people with neurodiversity. But if it's used in a moderate form, I mean, they used to use cattle prods and severe punishments in ABA, and that was obviously out of the terrible. But if it's used mildly, it can help, and I've no problem with it if it's used in a moderate, ethical manner. In terms of diet and autism, this is something I've been aware of for about 40 years. And there is one randomized, maybe more than one randomized controlled study of diet that's getting rid of gluten and casein, and that showed good follow-up, good results at follow-up. Another study didn't show anything at 6 months. But my clinical experience is, although this treatment is controversial, it is helpful in a proportion of children with autism. And I'm often asked about it. And I said it's a controversial treatment, but if a parent wants to try it, I think it's a reasonable thing to try. Next slide, please. Now, theory of mind was proposed as a theory of everything. It explained everything in autism. Well, it did not. And now there's been shown to be considerable non-replication of theory of mind. And a theory of mind has come under criticism as well from parents. It's been accused of stigmatizing and has been challenged by the neurodiversity movement. And theory of mind deficits have isolated and undermined people with autism, because people who have theory of mind, they've been told they're not suitable for work, and that kind of thing, and that is dreadful. But having said all that, the theory of mind concept is a generally useful concept, but it's not a theory of everything. Next slide. So the one area where there's only a few minutes left, so I'll get on, is diagnosing the dead. This is where people with autism, they have a lot of creativity, they have a lot of talents. There's quite a bit of savantism there, but this is people who are criticised who diagnose this, and I have diagnosed about 150. These are geniuses showing this because I'm so-called diagnosing the dead. But in medicine, they diagnose the dead every day. So with autism, autopsies and postmortems are incredibly important. Next slide. I'll just this is one example from Croatia. From the east as well, you have Kurt Gödel and Erdős. There are other famous geniuses who had autism, and he was an electrical and an engineering genius, inventive genius. He was loner and shy. He was abused by people. Big companies stole his ideas and didn't give him royalties. He was a novelty-seeking, sensation-seeking. He had narrow interests, preservation of sameness. So he's just an example. So the future of psychiatry then, since I'm coming to the end now. In the old days, we had psychoanalysis from Freud, and we had attachment theory for John Bowlby, and these completely dominated psychiatry in the 19th century. And Kraepelin was still strong in the 19th century with his categorical model, but those methods now are fading. And now what we have in modern times is the neurodevelopmental psychiatry, which and by neurodevelopment I mean ADHD, autism, tics, and schizophrenia and bipolar. So that is the new psychiatry. And where we should be going is this would be the ideal world if we could do our research on neural circuitry with a focus on genes, molecules, cells, circuits, physiology, behavior, and self-reports. If we could do that, we'd be like medicine, and that would be medicine. But we still have no biomarkers, and so after all this effort, we haven't even one biomarker. And the problem is we have massive heterogeneity in autism. And my last comment is that we need a new paradigm, a transdiagnostic paradigm, and we need, in a way, almost to start from scratch again and look at things much more broadly and not use false constructs, which we've been doing a lot in psychiatry from time immemorial. So thank you very much for listening. That's a lot.
Thank you very much, Professor Fицџeralд. It was really amazing presentation. I really like it because you mentioned very interesting topics about the history, about the psychiatry of autism spectrum disorders, and I would like to ask our audience to prepare before I give them the floor. I will say a few words about the presentation, about you. Dear audience, please raise your hand. It is on the top right of your monitor. If you like to give some comments or questions to Professor Fицџeralд. I'm really grateful to Professor Fицџerald because today he came back from Brussels. Even he is in his 70s, he's really enthusiastic and he wants to help to the younger colleagues. As you already saw in his presentation, he has articles since 1984, and most of you was not born then. And he has a really good practitioner and also theoretical experience in this field. Also, I didn't mention on the beginning that he's a board member of Journal for Real Touch Therapy and Development of Diversities, and also already published article, and I hope that in the future he also will submit some papers for you. That was we know each other personally since 2018. We met in one conference of Real Touch Academy, and since then we have a very good collaboration, and we have one common friend. It's Dr. Paola Bartolomeus. She was busy today and she could not join us, but she sends warm regards to you, Professor Fицџeralд.
Thank you.
Now, sorry, I must switch on Macedonian for some people who probably don't understand me. For the technicalities about the comments and questions. Почитувани присутни, повелете со прашања и коментари. Доколку имате, за жал рековме четот нешто не е функционален, блокиране од УКИМ и од ФЗФ. Не знам зошто. Наистина не ми е јасно. Имаше од 40 до 50 присутни, 1/4 од пријавените. Не е нешто многу добро, но не е ни лошо. Тоа е тоа. Дали имате прашања, подигнете рака доколку сакате да поставите прашање. Океј, сега ќе ви дадам збор. Можете да вашите прашања може да ги поставувате со аудио и со видео или само со аудио доколку имате срам или некои други објективни причини кои што не ви дозволуваат да го вклучите видеото. Okay, we have one question and just one more sentence. Most of the audience was from Macedonia, younger colleagues, special educators, psychologists. We have students from Institute of Special Education and Rehabilitation and Institute of Psychology here on my Faculty of Philosophy. And also I want to send the greetings to my dear colleague from Luxembourg, Jelena Tadic. She is a speech therapist with Serbian origin, and she lives there for 10 years, I think so, almost 10 years, I don't know really exactly. And also to my postgraduate student, master student from Slovenia, Andrea. And I'm sorry if I forgot to mention some other from abroad. Now I will give the floor to Anna Markovska to give you the question or some comments, please.
Thank you, Professor Trajkovski. I'm really, I feel pleasure to be here today, and I want to ask if you could put on a weight ADHD and autism. Is there a chance in any possible case for ADHD to be more severe than autism? I know that it might not be that connected to what we've talked about today, but I really wanted to ask. No,
this is a very good question. In actual fact, the patients with autism, they often come with ADHD. And ADHD is the presenting symptom and is the most severe symptom. So you're absolutely right about that. And but in the old days, before we recognized that ADHD and autism could come together, the ADHD was often missed. But I think the ADHD has to be treated fully. Separate from the autism. The autism has to be treated. The ADHD has to be treated fully in the usual manner. And if you don't treat both conditions, you don't get a good outcome.
Okay, thank you. Yeah, I hope that our student is satisfied with the answer. If you have more questions, please ask now. Now we are going to Irena Stojanovska, our postgraduate student on the Institute of Special Education and Rehabilitation, and she's writing a master thesis on autism. Please.
Good evening, Professor Fицџeralд, Professor Trajkovski. First of all, thank you for your presentation. And my question concerns diagnostic of autism. We having in mind that, as you said, recent genetic studies identified evidence of overlapping genetic risk for ASD and the other neurodevelopmental disorders. And we also have overlapping in some of the symptomatology. What, in your experience, is the best guidance to properly distinguish if a patient has ASD or some other neurodevelopmental disorder? As you said, instruments are not that reliable. We have no validated biomarkers, and the transdiagnostic multiomics approaches, as you said, they are promising, but they're very distant still. So I suppose it all still relies only and solely on the clinical experience. However, this has a big drawback. It is strongly subjective. It is very prone to bias. So what do you think, in your opinion, how can this process be aided so that more children can be correctly and diagnosed and in timely manner?
Well, I thank you for your question. Actually, all the points that you made are they are all correct. The instruments have some use in collecting data. They're good for collecting data, and you can use all the instruments you have for collecting data, and that's very helpful, and especially for beginners. It's important that they collect the data, because they will have difficulty collecting the data, and so they can use the instruments for collecting the data. But then the data has to be put into a diagnosis. The problem is that they're not diagnostic. They're not like a brain scan. And you've described the problems with clinical diagnosis as well, and the criticisms you make of clinical diagnosis is correct, but the gold standard the criticism you make of diagnosis is correct, but that's where psychiatry and psychology is. That's where the discipline is. So we have to live with that. There's no answers to the problem that you have described. But all we know is that the experienced clinician who's seen a lot of people with autism will make the best diagnosis. And you have to look for each diagnosis separately. Every person seen with autism has also to have a full assessment for ADHD, for depression, for anxiety, for behavior problems, for oppositional defiant disorder. And what we end up at the end is usually 2 or 3 diagnoses. You know, they're comorbidities, but they're not really comorbidities because they're kind of overlapping. They're not separate conditions.
Thank you.
Okay, thank you for this explanation about the comorbidities and about separate diagnosis and overlapping. It is very frequent in those diagnoses, really. Now we are going to the next question. Nada Dupjačanec-Nikolska, also our postgraduate student on Institute of Special Education and Rehabilitation, and she's very enthusiastic and she's writing a thesis, and both of them probably will defend this summer. Please.
Good evening to all of you. Professor Fицџeralд, I'm grateful for your lecture this evening, and I have a question for you about some of the things I've learned and heard this evening. Lots of diagnostic overlapping, lots of diagnostic instruments with differences in sensitivity, knowing a lot and have so much to learn and search about autism. I'm wondering, what are the chances to make right diagnosed at the age of 1 year? That's my question. Thank you.
Well, my answer, that's a good question. It would be a provisional diagnosis. I don't make final diagnosis at 1 year or 1.5. But the reason all I can say is that the reason for me being able to do that is I've diagnosed 5,000 nearly 50 years people with autism, and I think I know what autism looks like and what feels like autism, and that's what allows one to make a reasonably good assessment, even at 1 or 1.5. But obviously, you will also go on the history. You go on all. If there's a family history of autism, if there's a lot of problems sometimes in pregnancy, if there's lots of infections in pregnancy. And if there's genetic problems, I see huge numbers of all kinds of genetic problems, and all the children had autism. So it's you just try to put the whole lot together. Does this look like, and if they have a sibling with autism, or if they have 2 siblings with autism, all these things increase the likelihood that the child at 1 to 1.5 might have autism.
Yes, thank you. Do you have another comments or questions? Dupiačanec, Nikolska? No?
I would like to share also that my experience about working with children in the kindergarten and in the nursery are usually the same about the biting and presentation of aggression. In the early years, maybe as a sign plus for diagnostic criteria in ISD also.
I would just say about that, I don't know if I heard your question properly, but extreme aggression in preschool, in kindergarten, would be a red flag for me, and they should be sent for diagnostic assessment. It's the extreme aggression, because lots of children are a bit oppositional, a bit defiant, or they have a bit of behavior problems or whatever, in preschool, kindergarten. But it's when it gets extreme, and when they're biting or kicking or particularly vicious attacks, those should be sent for assessment.
Okay, I hope that the colleague Nada is satisfied with this explanation and your answers. I really hope that we have today a very nice webinar, and I hope that our listeners and our audience will be very satisfied. Are there any other questions? Други прашања, коментари, или полека да затвораме? Do you have more questions? You must turn on your audio and video, or only audio. If you have questions, because the chat on Microsoft Teams today doesn't. Please? No. Okay. More than 1 hour we are together. It's time to finish this very, very interesting webinar. For today, I really want to say thanks, Professor Fицџeralд, for your time, and I wish to be vital on your ears. Firstly, to survive all those pandemics and wars and all this stress around us, everyday stress, and to survive 70s and to be vital as much as you. I hope that our collaboration will continue in the future. I wish you to stay safe and healthy, and to work as you work in all those years in your career, and even you're retired, you continued with your scientific and research work. Also, I wish to your family good luck and health, And also, I want to wish to our audience a lot of health and to stay safe in the following days, and to announce the next webinar on 18th of March with Dr. Jackie Ashton-Smith from London. We'll have another interesting and practical webinar about the woman and about ladies, girls who have autism. So if you want to say something for the end of the webinar, please, or if you don't have, we will say goodbye.
Goodbye.
Okay, goodbye to all of you and take care, please.
Thank you.
Thank you, yeah. Now I will turn on Macedonian, and if you wish, you can leave the meeting. Благодарност за сите што присуствувавте за време на овој вебинар, што одвоивте дел од вашето драгоцено време, што не удостоивте со вашето присуство, помеѓу 45 до 50 максимум учесници. Добро, тоа е македонскиот интерес за науката. Очигледно дека минатиот пат 100, бидејќи имавме долга пауза и тоа беше веројатно, може би имало и повеќе заинтересирани, но тогаш бевме на Zoom. Сега решивме да одиме на Microsoft Teams, но за жал и покрај што јас не очекував дека ќе има 216, но се надевав барем 100, но добро, тоа е тоа. Презентацијата ја има заедно со keynotes, забелешки од секој слайд на македонски на YouTube каналот на МНЗА. И ви најавив дека на 18 ќе се видиме. Доколку не сте се пријавиле, за сега има 73 пријавено. Пријавете се, сторите го тоа во наредните денови, бидејќи некаде пред вебинарот ќе биде заклучен можноста да се пријавите и нема да добиете мејл со линкот за следниот вебинар. Ете, толку. Да не се преведувам сега и на македонски што се ви посакав. Здравје многу и да бидеме во одлична ментална и физичка кондиција на 18 март, да можеме да одржиме уште еден ваков добар вебинар, може би со поголемо учество, може би со помало. Тоа зависи од вас, не од мене, не од нас, од МНЗА. Тоа е тоа. Ете, толку. Сега јас полека ќе се исклучувам. Прво да го затворам снимањето овде на платформата и потоа исклучувам полека и микрофон и камера. Ви благодарам, пријатно.